is your diagnosis of cardiac syncope. And if there is one study, I'm not really a literature person, I'm really just a clinical knowledge translator. If there's one study that I think you need to know about, is there was a study in Annals in 2018 that showed 3,600 patients, 1,400 with near syncope, and 2,200 with syncope. And these were all geriatric, they were older patients. And they looked at this cohort of old patients for 1 month. And what they found out is whether you have near syncope or syncope, the outcomes are identical. So what this means is if someone almost faints or someone faints, you need to treat them the exact same way. I think a lot of times we say, oh, you almost fainted, you're okay, you didn't actually faint. That is meaningless. You must treat these two groups the same. When I was younger, I used to think that cardiac syncope meant you had chest pain, you had palpitations, and you fainted. Cardiac syncope is this. Boom, you went down with no warning. If you break your teeth, if you break your glasses, you have to realize how important those are in terms of predicting cardiac syncope without warning where you didn't have time to yourself. I remember seeing a young woman, she was about 26. She came into the emergency department, and the first thing she said to me was, I'm so sorry for wasting your time. Do people apologize to you in Turkey? No. So this was the problem. They don't apologize in Canada either. And what I know is that the nicer people always have worse outcomes. So I was already very concerned about it. So she said, I'm so sorry to waste your time. I should be at the dentist. I chipped my tooth. Okay. Well, what happened? Well, I was taking a shower, and the next thing I know is I'm on the ground and my tooth is gone. Okay. And what happened before I don't know. I just woke up on the ground. So I didn't like her story. She went down without a prodrome. She went down without pre-syncope. To me, this is cardiac syncope. So I told the specialist, you have this young woman, she just dropped to the ground with no warning. I'm very worried about her. So the first thing they said is, what's her troponin? I said, troponin? Who the hell cares about troponin? Sorry, I know Lisa's giving a talk on troponin later. This is not a troponin talk. You have 2 troponins. Listen, I could do 1,000 troponins. It's nothing to do with troponin. Okay. So they come see the patient and send her off. And I get a call from my colleague, Carolyn, about a month later, and she said, remember that patient you saw? I don't know how to say that in Turkish, but it makes us all very nervous. I don't know. What are you talking about, Carolyn? Spit it out. She said, you saw this woman, she was young, she fainted, she broke her tooth. Yeah. Well, they sent her home, and I did a Holter, and it showed nothing, but I didn't like her story. So I did an implantable loop recorder. She had an episode of torsades. She had long QT and torsades. And the best part about it, David, is that she has an identical twin, and now they both have different twins. This is all taking history. If someone doesn't have pre-syncope, if someone doesn't have a prodrome, you must think about cardiac syncope. Any history buffs in the room? Anyone know who this is? Good. You're not supposed to. So this is Pheidippides. Ring a bell? So Pheidippides is the fastest runner in Greece 2,500 years ago. And he's stationed in a city called Marathon. And the Greeks are being invaded by the Persians. He goes to tell the people in Athens about the position of the Persians. He runs 26.2 miles, just over 40 kilometers, to Athens. He arrives, he warns them of this attack, and then he's dead. And he's the first incident reported of sudden cardiac death in sports. If you die while you're exerting yourself, you have to be worried. And you will see people, whether you're Christian Eriksen on the soccer pitch, you will see people just drop. Cardiac syncope and exertional syncope need to be treated with respect. This guy had a marathon in that. Often patients will have a hard time deciphering, or bystanders, was it a seizure or was it a syncope? 90% of people with syncope will have a few myoclonic jerks. When you drop the perfusion blood flow to your brain, you will have a few jerks. Now, people will look for the following. Yes, if you have epilepsy, you probably had a seizure. Being post-ictal, very helpful. People will always look for tongue biting. What is important to know is if you fell down, you will bite the front of your tongue. But if you have a seizure, you bite the sides of your tongue. Lateral tongue biting is much more specific for a seizure than central, 96%. So look for lateral tongue biting. Things like incontinence or prodrome aren't that helpful. What I like to use is the 10-20 rule. Has anyone heard of the 10-20 rule? This is a very helpful rule. If you have less than 10 jerks, it's syncope. If you have greater than 20, it's a seizure. This is very helpful when you speak to the people who witness this, the scared family members. Say, was it just like a few of these, or was it 20? That is an important rule, the 10-20 rule, to distinguish between syncope and seizure. I often will ask about family history of sudden cardiac death. You know, and I never hit it. I never kind of get anywhere with that question. I think what's more important to understand is there's another question you want to ask people who syncopize if they're young. Has anyone in your family had a motor vehicle collision and died for no reason? Or has anyone in your family drowned? If you drown, unless you're drunk, unless you break your neck, if you know how to swim, you have to look at this as an opportunity to do some testing. If you're 25 years old and you drown in a pool, that's not normal unless you don't know how to swim, or there's strong waves or current. So instead of just asking about family history, ask about drowning or unprovoked motor vehicle collisions. Paramedics. Paramedics hold the Holy Grail. They hold all the information that when they leave your hospital, you must make sure that you've seen what they leave with. My grandmother had an episode when she fainted while brushing her teeth. I got a call from her caregiver who said, your grandmother has fainted, they're taking her to a hospital nearby, her heart rate is really slow. I get to the hospital, and she looks great. I see someone who is one of my residents looking after her. He says, your grandmother looks great. Her blood work's normal. Her troponin is normal. Like, I care about troponin. Her ECG is normal. She looks great. She's ready to go home. I said, can I see her rhythm strip? What? You know, the paramedics must have a strip, and I heard my grandmother's heart rate was slow. Do you have that rhythm strip? No. Where are the paramedics? Oh, they're just over there. So when you looked at her strip, she was in complete heart block. She got a pacemaker, and we had her for 10 more years. You can't let EMS leave if they have something on the strip. You know, right before I was giving this talk, I don't know if it's the same for you, but whenever I'm giving a talk, always something cool comes my way. I saw this 80-year-old woman a few months ago. The paramedics brought her in, crushing chest pain, high-risk ECG features. They told me the story. Yeah, we brought her in. She was having significant chest pain, and we lost her for a little bit. Now she's here. Wait, you lost her for a little bit? What do you mean by that? Oh, well, we don't know. We couldn't really get her pulse, but she's back now. You have a strip? No. Was she on the monitor? Yeah. Can we look at the monitor? Huh. She had a run of VTAC. That's a little bit different. We just lost her. So that chest pain with we just lost her now went to the cath lab. It's all about the history, and it's all about getting that strip. If you have a pacemaker, you have it because your heart sucks. You have to realize that you can't blow off people with pacemakers and say, yeah, it's just vasovagal syncope. I know it's a pain in the ass, but if someone has a pacemaker and they syncopize, you need to have that pacemaker interrogated. That's not something that's easy to do at all hours of the night, but you have to assume that people with pacemakers have cardiac and have something wrong with their device. There's some young doctors in the room. This is a stethoscope. It's like an ultrasound for your ears. It's embarrassing that during COVID, people stopped examining people in Canada. If someone has syncope, you better put that stethoscope on their chest and listen for the murmur of aortic stenosis. Picking that up saves lives. This is the physical exam. Listen to people's hearts. There's not really a role for lab work. Syncope is not like the troponin thing. Yes, if a woman comes to me and says, I've been bleeding for a month and now I syncopize, of course a CBC is relevant. But you're not going to make brilliant diagnoses with labs. You're going to make a brilliant diagnosis with your ability to take. And I also think it's important to realize that in the setting of you think someone has cardiac syncope, you really have to say, would you want this person driving your kids to school? And do you think this person is safe to be driving? In Canada, if I feel that someone has a seizure or cardiac syncope, we would report them and they would be not able to drive until they can. That is a safety issue. Okay. I have to talk a little bit about ECGs. But if you were the marketing manager of McDonald's and you were telling people to have Big Mac and fries, you would think that you wouldn't have a rhythm strip that shows some wonky P waves and then a run of non-sustained VTAC. But hey. This is WASM, so we're not going to talk about blocks. But if someone comes in with a heart rate of 30, unless they're super fit, you could assume that's the cause of their syncope. Let's go through a handful of cases of ECGs that I think you need to know about. These were two of my idols growing up, Reggie Lewis and Hank Gathers. Both of them died on the basketball courts, and both of them had issues beforehand. Hank Gathers had a slam dunk and fainted at a basketball game a week before his death. During his death, which was on national TV, he went up and he dunked, he came back on defense, and then you could see Gathers drop without any warning. There was no prodrome. Gathers proceeds to go on to have about 3 or 4 myoclonic jerks, and then he dies. If you saw Gathers in your emergency department a week prior when he fainted, you would have seen this. You would have seen an ECG, and the first thing you would have said to this 18-year-old or 21-year-old gentleman is, he's got, looks like an old inferior lateral MI. He's got some Q waves in 2, 3, AVF, in V5 and V6. His voltages are up, he probably has LVH. What you have to realize about LVH is LVH doesn't happen overnight. Left ventricular hypertrophy is because of a process such as hypertension or aortic stenosis. If you have someone who has LVH who's not hypertensive, you have to think about why. And in this setting, this is classic for hypertrophic cardiomyopathy. When you see hypertrophic cardiomyopathy, you will see LVH without hypertension. You will see Q waves, which are not pathological. Pathological Q waves are wide. These are dagger-like Q waves in the inferior lateral lead. This is the number one cause of sudden cardiac death in sports and the most heritable cause of sudden cardiac death, 1 in 5 worldwide. Don't miss this opportunity. A couple came to see me. They were paddling in our waterfront. Our waterfront doesn't look like yours, and it certainly doesn't look like this. And in the distance, they saw ice cream. So they biked really fast, really fast. The woman in the front, she got off to get ice cream, and then she drops. You don't even need to see her ECG. She has exertional syncope. In your mind, you're done. She's got a problem. She has cardiac syncope. But what she hands you is a great ECG. Now, we always tell our trainees, don't read the stuff up front. In Canada, the EKG comes with an interpretation. Does it come with an interpretation in Turkey? You know, it's often wrong, but what's not wrong is the PR interval, the rate, and the QRS, and the QT. So when you look at syncope patients, check the box. When you check the box, the first thing you say is, crap, her PR is short. And then you go and you hunt for delta waves. And this is a very classic EKG for WPW. If you look at lead, it's best in lead AVL, you could see that delta wave is that blocking, that obtuse upstroke to get from the isoelectric baseline to the top of the R wave. It's sloped upwards. But even without the ECG, you know her story's bad because she had exertional syncope without a protein. You're done. I saw this gentleman, he was 34, kind of went to his family doctor. He was feeling dizzy with some palpitations. He got an EKG. He came to me with a fever. He wasn't feeling well. An ECG was done. And the top of our ECG said two things. It said, this person is having an acute MI, and it also had my, so I knew I couldn't fuck up, okay? And I looked at this ECG, and he's a young man, and I said, he's not even having chest pain. But I looked at his ECG. What do people think about his ECG? Yes, Brugada. So this person has ST elevation in his precordial septal leads in V1 and V2, that's downslope. I'm going to tell you two things about Brugada. One, in the setting of fever, they are a lot more arrhythmogenic. So this is when people will show up, they'll have a fever, and you'll kind of think there's nothing wrong with them because they have fever, they don't feel well, they might not even get an ECG, but that's when Brugada comes up. Number two, if you see this guy tonight while you're on shift in the emergency department, there's a 10% chance, if you don't make this diagnosis, that he's dead before Turkey turns 101 next year. The rate of death in missing Brugada is 10% per year. Don't miss Brugada. Anyone rock climb? Any rock climbers in the room? Not a big rock climbing room in Turkey. This young woman is rock climbing with her partner. She gets up to the top of it's an indoor rock climbing, gets up to the top of the and you don't even need to see her ECG. Exertional syncope without warning. But she hands you a gift. It's a gift that you will see once in your career. When I saw this, I was so happy for like a year. I looked at this ECG, and the first thing I said is, there's T-wave inversion in V1, V2, V3. I don't think it's the Wellens. She's not having chest pain. She's not having syncope. Does anyone want to hazard what this is? So I looked further, and when you look at her, you can see when you go back. In WPW, it's really hard to get to the top of the mountain from the baseline. She has something called ARVC, arrhythmogenic right ventricular cardiomyopathy, used to be called ARVD. She goes to the top, no problem. She goes down, no problem. But from the nadir of the S wave to the isoelectric baseline, it's blunted. It's kind of like a reverse delta. And in that area, there's a little blip called epsilon wave. You can kind of see it in V2 here, where up, down, but then it's really hard to get to the baseline. This is ARVC. Again, her story was everything. One more ECG, and then I'm done. You guys see old people in the emergency department in Turkey? This woman has come to our emergency department 5 times. She's on an oral anticoagulant, and a Pixaban, and every time she comes, she gets a CT head. It's normal, she goes home. CT head, normal, go home. CT head, normal, go home. CT head, normal, go home. I see her on the 5th visit. Every single time, her ECG looks like this. Nothing has changed. If you read the printout, it says bifascicular block. Okay. You got 3 fascicles. If 2 of them are down, and you're 80 years old and you keep fainting, you're screwed up. You have to assume that that has something to do with your fainting. In her case, she has a bifascicular block plus a first-degree block. She has a first-degree block. If you have syncope plus a bifascicular block, if you have syncope plus a bifascicular with a first-degree block, you and I might have called that a trifascicular back in the day, or someone to consider that. They don't keep needing CT heads. Use your head. They need to see a cardiologist, not a neurosurgeon. If you like to take pictures, take a picture of this. When I see everyone with syncope, I look for 5 things. I look for WPW. I look for ARVC. I look for Brigada. I look for HCM. I look for long QT, and I talk. I go into every ECG looking for those 5 things, and then I move forward. But I know that that's my approach when I see an ECG, but I take value in the story. So what can I tell you to end this morning? History is queen. History is everything. Make sure that you ask people what they were doing before they fainted. The establishment of pre-syncope, absence of pre-syncope, should always make you nervous. These people don't need workups, they need you to take a great history, and take an ECG and look for 5 things. The EKGs are gravy. They're a gift. Just know how to look at them. Thank you very much for your time.
As Dr. Carr said, we're going to hold the questions till the end because we're a little bit behind schedule. Our next speaker is going to be Dr. Lucas Sarspak. If I pronounced your name correctly, I apologize. I did good? Okay. All right. Professor Dr. Sarspak is going to speak to us about manual CPR versus automatic or automated chest compression device. Something very common to everybody's emergency department is this question. Thank you so much, Dr.
question was nearly correct. As I'm, as you see, director of the clinical research and development at the LuxMed Group in Poland, but I'm also president of Polish Society of Disaster Medicine. I will talk to you about the automated or mechanical chest compression devices. We know those devices from many years, but the same as during my previous speech, for focusing on epinephrine, we have many studies, but with those studies we have much more questions, and this is problematic. So I will start. Of course, we know that according to American Heart Association, as well as European Resuscitation Council guidelines, the most important thing during resuscitation is high-quality chest compression. High-quality chest compression composed of the correctly rate of chest compression, correctly deep, poor recovery of the chest compression. But we know that in some cases it's difficult to obtain, and I will back those situations in the next slides. Of course, currently we have many types of mechanical chest compression devices. We know that we use it in pre-hospital as well in hospital cardiac arrest situation, but the use of mechanical chest compression increased during the COVID-19 pandemic, mostly, for example, in Poland, from my experience, because the pandemic show us that we have increasing number of the cardiac arrest situation, and different studies show us that, for example, when we know the outcomes of mortality of those patients, 85% of patients died compared to the only 62 in the pre-pandemic setting. So we know that this is most important thing. And when we're talking about those devices, we can talk about each device and we can show some advantages and disadvantages of each device, and I will show you some perspective of these devices. And of course, all of us know the Lucas. Lucas right now has third generation of this device. It's, I suppose, the best recognizable mechanical chest compression device worldwide. Most studies do this on Lucas, so we have some research background of those devices. We know that this is a piston device. It's commonly used, for example, in the EMS in which I'm working. I mean the EMS in Warsaw. This is the biggest EMS dispatcher in Poland. We have right now 88 ambulances in our region. About 60% of devices which we have in ambulances are Lucas devices. So, as I say, Lucas device in Poland is mostly commonly used, and I suppose in other countries also. What is important, Lucas device we can use only on the adults. It's contraindicated in very obese patients as well as in the pregnant patient. The philosophy of this device is to create the active decompression suction on upstroke, and it's important for this device. The second device is, for example, Zoll. I saw this device also in this area, and this is nice device, but I personally don't use it because, as you know, Lucas is much more better, mostly for me. But of course, we have Zoll device, so Zoll AutoPulse device is low distributing compression band to compress the chest. And it can be used only under patients under 130 kilograms. It can be used only on adult patients, and it can be used only on non-traumatic cardiac because when we have the problems with the chest, it will be problematic to use this device. When we're talking about other devices, one of the nearest new device is Corpus CPR device. And this is nice device because we can change many things on it. We can use it even in adolescents, in adult patients. We can change the depth of compression, we can change the rate of compression, so it's nice for us to change the quality of compression of these patients. However, as you see on this slide, I know that maybe it's not good quality, but it shows us the most significantly research using on the chest compression devices. And when we talk about it, one of the important study was the Aciltv trial published in 2014 in resuscitation. This was randomized control group sequential trial using on the adult out of hospital cardiac arrest, where the presumed cardiac origin of the cardiac arrest, and it was conducted in the US and in the European. In this study, authors compared the auto-pulse and manual chest compression. They create some outcomes such as survival to hospital discharge, and in this study they don't show significant difference between auto-pulse and manual chest compression. This is important for us because firstly, the chest compression is important, as I talked previously, but when we perform such a study, we should focus also on some criticism of the study, because majority of patients were excluded in this analysis, excluded post-random for various reasons. Bleeding was not, for example, possible due to the blinding of the study was not possible during this study due to the intervention type. But for example, 20 minutes CPR fraction was higher for the manual chest compression. And this is possible, we can explain this by the photon effect. Maybe you know this effect because the photon effects occurs when the participants' behavior, when they are observed, because when you are observed, your behaviors are changing. When someone observes you during resuscitation, you perform this resuscitation much more better. You perform higher quality chest compression. So when we compare on the one side the manual chest compression, on the other side mechanical chest compression, and this is observational study, we probably will perform much more better manual version of chest compression. Moreover, this study was not powered for a long-term period outcome, because such as, for example, 6 months survival rate or 6 months survival rate with the good neurological outcome. We only, in this study, they only saw the short periods. However, in this short period, the difference between those techniques of chest compression, as I say, was not statistically significant. The second study is the LINK trial, published in the same year, I'm in the 214, this time in JAMA. This was also randomized trial, this time involving 4 Swedish, 1 British, and 1 Dutch ambulance service. In this study, they involve only out-of-hospital cardiac arrest. However, the previous study was focused on auto-pulse. This study was focused on Lucas, and I suppose it was a huge group because the arm in which the patients were treated with the Lucas, they involve 103,000 patients. Near the same number was was put to the manual chest compression group. The problematic of this study is fact that they, as a primary outcome, focus on 4-hour survival rate, and this is not oriented of the patient outcome. However, the differences between those groups were similar because it was 23.6 for Lucas and 23.7 for manual chest compression. So the risk difference was over than 0.99, so it was really similar. Besides, no difference in the secondary outcomes. I mean, the good neurological recovery was also found between those groups. As I say, the primary outcome was 4-hour survival rate, and it was not patient-oriented outcome. Moreover, among patients with surviving at 6 months, 99% in the mechanical chest compression group, I mean in the Lucas group, and 94% in the manual chest compression group at the scores of CPC at the level 1 or 2. However, the 4-hour survival rate was not difference between those groups. The next study on which I want to talk about is paramedic trial, paramedic 1, the first one study, because as you know we have two studies, paramedic 1 and paramedic 2. And this study was conducted in UK in NHS ambulance service, also focused on the out-of-hospital cardiac arrest. This time evaluated the chest compression techniques in 2 groups, in Lucas and manual chest compression. The randomized was 1:2. So in the Lucas group, they involve 1,652 patients, and in manual, 2,819 patients. And this was randomized according to the first trial vehicle to arrive on the scene. However, when we're talking about, one more time, about the outcomes, the primary outcome in this study, which was the survival to 1 month, was 6% in the Lucas 2 and 7% in the manual chest compression. No serious advanced events was noted, and this is also important because one of points in which we, in studies, it's the fact that mechanical chest compressions occur much more chest compression chest injuries. However, in this study, intervention to treat analysis was used, and this is problematic because, for example, when we see only in 60% patients in the Lucas group received formally mechanical chest compression. So if they will do, for example, not only intention to treat, but per protocol analysis, it will be much more better for this study. However, as I say, there was not any serious adverse events during chest compression with Lucas, with manual chest compression the same, and the survival in those studies was similar in both cases. When we're talking about the guidelines, because when we have the guidelines, we have, as I say, American Heart Association guidelines, we have European Resuscitation guidelines, we have ILCOR about that. The current research does not support, to mention the mechanical chest compression devices, I mean the mechanical pistol devices or load band distribution devices. They don't offer any advantages. Manual chest compression in patients experiencing cardiac arrest. The current standard of care for management of cardiac arrest is still high quality manual chest compression, so we should obtain some extra trainings. According to the guidelines, every 3 months we should perform simulation trials on the chest compression. However, mechanical piston devices can be considered in some kind of situation, and for example, such scenarios can be limited to include the limited space for rescuers, incidences of prolonged cardiopulmonary resuscitation, hypothermic cardiac arrest, CPR in the moving ambulances, CPR when we prepare the patient to the angiography or preparation to the ECPR. So in those situations, we should use high quality chest compression performed by mechanical chest compression. However, in the crucial for rescuer is to minimizing the interruptions in the CPR. So it's not depend if we use mechanical chest compression or manual chest compression. We should previously train it to minimize this interruption and perform as high quality chest compression as we can. I want to talk to you about also some meta-analysis, because as you know, meta-analysis are one of the most important type of studies which we focusing. And for example, in this meta-analysis performed by ZOO, they include 15 trials, 9 randomized controlled trials and 6 cohort studies. The results of this meta-analysis showed there was no significant difference in the resuscitation effect of mechanical and manual chest compression in terms of the return of spontaneous circulation, survival to hospital admission, survival to hospital discharge, and survival to hospital discharge with good neurological outcome. This study focusing, of course, on the out-of-hospital cardiac arrest patients. The next one study is, in this study, for survival to hospital admission, the pool estimate of the randomized control trials did not indicate a difference between mechanical and manual chest compression. However, when we see the subgroup of non-randomized control trials, the difference was statistically different, and manual chest compression performed much more better survival rate. So, possible we can also talk in this space about Hawthorne effect. Survival to hospital discharge outcome did not differ between those strategies when we summarize all RCTs and non-RCTs trials. And this is also important for us. What the next? When we talking about the consideration of safety context, we should talk about advantages and disadvantages of the using mechanical chest compression. And when we're talking about advantages, for the first, it allows us to perform the consistent quality of the chest compression in the long period of time. The second one is important for, as I say, prolonged resuscitation, post-thrombolysis, hypothermia, cardiotoxic overdose, transfer to the special units, I mean ICU, hemodynamic, cath lab, or ECMO CPR. The next advantages which I see is that defibrillation can be safely performed during chest compression. Another thing is that when we secure the airways, we can perform continuous chest compression without any breaks for the ventilation. And in this way, we minimize the interruptions to compressions. Moreover, it's safe performance of chest compression during transfer the patients, for example, in ambulances or helicopter emergency medical services. When we're talking about disadvantages, because this is also an important thing, it's, according to those studies which I show you, not found to be superior to the manual chest compression in major studies. Requirement, staff training and familiarity with this equipment is needed to perform correctly application of those devices on the patients. Another adult devices are not suitable for pediatric patients. Only one device can be used, and this device is corpus CPR. And some of those devices cannot be used, for example, during PCI, such as ZOL, because we have limited space and for the chest. When we're talking about the future, what we need to, if we want to use those devices, if we want to use manual or mechanical chest compression, we must ask ourselves several questions. Firstly, is mechanical chest compression useful in situations in which we are, I mean in the hospital or emergency department or ICU, depending on us? Who should apply the mechanical chest compression, we or something from our team? Can the efficiency and safety of mechanical chest compression devices be improved with simulation training or pit crew model of in-hospital cardiac arrest? Because this is the second important thing, because we use, of course, mechanical chest compression devices in the pre-hospital setting, but we should also use in the in-hospital circumstances. Does deploying of mechanical chest compression earlier during resuscitation lead to better outcomes compared with manual cardiopulmonary resuscitation? To answer to those questions and to know better mechanical chest compression in the field of safety and efficiency of the cardiopulmonary resuscitation, in my perspective, we need much more. Nice. We need much more data, and for this we need to accommodate people from different countries, from different regions, and create one big international multi-center registry, some database, in which we collect all situations when we use the manual and mechanical chest compression, because when we working on small numbers, even if it's about 1,500 in each arm, it can be the Hawthorne effect. But if we will have 10,000 or 15,000 of patients in each arm, I mean in the manual chest compression and in the mechanical chest compression, the Hawthorne effect disappear. Moreover, we have a lot of different devices of mechanical chest compression, and we should also randomize those trials, randomize those devices, and see relatively effects of each device on the cardiopulmonary resuscitation outcomes, because right now mostly studies focusing on Lucas 2 or Lucas 3 currently, and autopulse. On other mechanical chest compression devices, there is a lack or small number of studies which show us the efficiency and mostly the safety of those devices. And I suppose that's all. Thank you.
Thank you, Lucas. Our final talk, we'll have questions after. That's Lisa Moreno. She's going to talk on I remember. Lisa, thank you so much.
Okay. So this talk is on point-of-care testing for optimizing management of acute disease in the emergency department. And where is my, here we go. Okay. So typically in the American fashion, I've included my disclosures because that's mandatory in the U.S., not so important for here. So I want to review the point-of-care tests that are available in many or most emergency departments and assess What are the implications of positive results utility in optimization of management of acute diseases in the ED? And why does this matter? You know, globally, we're all having the same problems in our emergency. They're overcrowded. And one of the reasons is length of stay. And part of that is time to discharge. So our patients are waiting for results, and then sometimes there's over-ordering that takes place. So we have to act on incidental positive results that we didn't really want to get in the first place. The other issue is time to admission, right? So there's either missing data and the admitting team won't take the patient, or there's no bed upstairs. So yes, boarding is the bigger issue, but we can't control that. At least most of us can with our hospital administrations, and so we have to focus more on what we can control. Also, there's an increased cost of care globally. It comes partly from indiscriminate ordering and shotgun ordering and inadequately trained providers. And those of you who know me and those of you who know the organization that I'm the immediate past president of, didn't introduce that. I'm a tenured professor in emergency medicine at the institutions, and I am the immediate past president of the American Academy of Emergency Medicine, and we are vehemently opposed to the use of the word provider. I didn't go to provider school. I am not a provider. I'm a physician. I have specific training. I have a specific knowledge base and skill set and communication ability that makes me an emergency physician. We believe at AAM, and I believe personally, that board-certified physicians should be in charge of every healthcare treatment team. And that is part of the problem, is that you often see that there are non-physician, quote-unquote, providers who do a lot of shotgun ordering and a lot of not understanding how to order. My perfect example of this is a 16-year-old girl I had recently, and when I went to look at her, here she was, she had a fever, and she was coughing, and she was mildly tachycardic, and the nurse practitioner who saw her initially had decided that she should go into a sepsis protocol because she was febrile and tachycardic, and that she should, of course, her blood pressure was a little on the low side. And why was that? That was because she's a female and she's 16 years old. And I went in the room and I said, "Sweetie, are you having chest pain?" And she said, "Well, not really, but the nurse asked me if when I cough, if I had chest pain," and I said, "Well, when I cough, I get chest pain." So she got put in a cardiac protocol as well as a sepsis protocol, and 1 million tests ordered. And I said to her, "Sweetie, did you have a flu shot this year?" And she said no. And I just did a point of care rapid flu, which was positive. And I treated her and sent her home. So the problem becomes that, you know, it's like the story of the blind men touching the elephant. What you know is all you know how to do. And this is why part of what I'm going to talk to you about point-of-care tests is the fact that point-of-care testing starts with a qualified physician who looks at a patient and is able to do a clinical assessment and decide on what point-of-care tests are necessary. Point-of-care tests don't give us a diagnosis. They confirm the presence of a symptom, not the underlying cause of the symptom. I've given a couple of examples there. So they guide our ordering of tests. The way this should be done is a qualified physician should examine the patient quickly, do a focused assessment of the patient, order point-of-care tests, and then the point-of-care tests, based on their results, guide us as to what focused testing we need to do next. Because the emergency department is about focused care. We're not family practice doctors. We are not running a clinic. We do focused care. That is what the patient came in for, that problem, and we are addressing that problem for them. So what about the pregnancy test? This is the most commonly done test in the world, the most commonly done point-of-care test. Women often don't know they're pregnant. You know that. And there are many reasons for that. They can have irregular menses. They could be perimenopausal and be having irregular periods because of that. Some women don't keep track of their periods. And the statement that I haven't recently had sex doesn't mean you're not pregnant. Because I may not have had sex recently, but maybe I did get pregnant the last time I had sex, and I've been pregnant for weeks and not keeping track of my period. So the test should be done. And a positive test, of course, doesn't only mean that a patient is pregnant. And this is where the training of a skilled physician, the education that we get in medical school and residency training comes into play. A positive pregnancy test can also mean that I recently had a miscarriage or abortion, or that I recently delivered a baby, or that I'm responding to medical therapy for an early pregnancy. And so what do? I'm going to use the pregnancy test as a way to show how you can be guided into the appropriate treatment based on your assessment of the woman at a point of care test. So usually you're going to get a good history then, a beta 1. But if she's pregnant, that abdominal pain, you're pulling out your ultrasound to do point of care, which is another point of care test, right, for ectopic or heterotopic. She's pregnant and bleeding. You're going to do a POCUS to determine her gestational age and evaluate her for threatened incomplete or complete abortion, or in late stage pregnancy for a previa or an abruption if she also has pain. If she's febrile, has an elevated white count, you want to know, did she have a recent delivery, miscarriage, or abortion? And then you're going to do a POCUS for retained products or perforation if that's appropriate, if her history and she's had pain. You can also ask if she's getting therapy for an early ectopic and then follow her earlier betas and consider a POCUS. Now, of course, in trauma, we always get a pregnancy test. We want to know if the mother is pregnant. We also know the mantra of trauma that a dead mother means a dead fetus. But why do we want to know if she's pregnant? Some of the exams that we do, shielding is possible, right? So if I think she has a femur fracture, I can still shield her abdomen. If I'm looking for a pneumothorax, I can still shield her abdomen in those cases. So what's the second most commonly performed test globally is the point of care glucose test. So what would you, as a seasoned physician, go in and talk to the patient and you notice the following, right? The patient is confused and altered mental status. My colleague, Dr. Carr, talked about the importance of EMS. Our EMS often does a point of care glucose test when they encounter a confused or altered mental status patient in the field. Does it happen in Turkey as well? Do you see that EMS does point of care glucose? Yeah, that's very, very helpful, right? Because they could have hyperglycemia. Sorry, that should have said hypoglycemia. Or they could have hyperglycemia with a hyperosmolar or coma. Also, you can ask the patient if they've had new onset polyuria, polydipsia, or thirst, because this, or a new onset infection, because this could mean then that you're making a brand new diagnosis of diabetes in the emergency department. And remember to consider in pregnancy an elevated glucose, or even in pediatrics, because it's the type of diabetes that occurred and gets diagnosed for the first time in the ED. So what does a positive result mean? Well, the patient can have hypoglycemia, and that's what's causing their altered mental status. But that'll guide your immediate treatment, because then you're going to give them a glass of orange juice, or if they're completely obtunded, then you can give them an amp of glucose, right? Etiology determines further treatment and is also going to determine your disposition. If they're hyperglycemic, you can make that diagnosis just based on the finger stick, and then you can also make the diagnosis of new onset diabetes. Then you're going to know, right? So again, my protocol is that you go in as a seasoned physician, you do a rapid focused assessment, you order a point of care test, and that guides you to do focused ordering going forward. So here you are, you get this elevated glucose in this patient who has a new infection, and then you're going to look at your anion gap, your osmol gap. You might do a blood gas to further guide treatment and make your final diagnosis, and then make the appropriate disposition for that patient. Do they need admission? Do they need antibiotics? Can they go home on antibiotics? What do you need to do to get their glucose down? What is the agent that they're taking taking at home that has caused them to be hypoglycemic, and what is the half-life of that agent. So again, all of your skills as a physician come into predicting what point of care test you want to order. And so we've only looked at 2 point of care tests, and already we've seen how ordering can become more streamlined and efficient, how treatment can become more prompt and targeted. You're reducing your door to dispo time, and you're reducing the cost of care for both the patient, who has to pay in some countries, including the United States, who has to pay for some of their care, but it's also in decreasing the cost to the hospital in terms of time or money. So when do we think about getting a point of care urine dip test? That's the third most commonly done test. The average woman will get 3 UTIs during her reproductive years, but women who they know when they have a UTI, you can actually what we call treat and street, right? You can treat them, send them back out into the street, discharge them from the waiting room or the triage area simply by getting a urine dipstick. The UTI in the elderly, however, is a frequent cause of sepsis or AMS or confusion. So if they're altered, if they meet sepsis criteria, you dip their urine, you have a diagnosis, you can start early and targeted antibiotic therapy. Now, the other thing we sometimes lose sight of are vital signs. Vital signs are actually a point of care test. We don't often consider them as such. But, for example, when you put a pulse oximeter on a patient and you measure their oxygenation, that helps differentiate the chief complaint of I can't breathe, right? Often patients are saying they can't breathe, and is it always pulmonary? No, sometimes it is some sort of an obstruction, right? That they swallowed something, there's partial blockage of the trachea, or even food stuff in the esophagus that makes them feel that they can't breathe, or sometimes our exclusionary diagnosis of anxiety. Their response to supplemental oxygen is also going to suggest your further intervention and test, combined with tachycardia. Hypoxia could mean a PE. Combined with fever or tachypnea, you may want to rule out COVID. You also need to anemia, and you can quickly, as a seasoned physician in the triage area, look at the patient's conjunctiva or nail beds when they're saying that they're shortness of breath, especially on exertion, and then you know that one of the tests that you're going to order going forward is a CBC. Vital signs are vital, again, so looking at tachycardia, hypertension, hypotension, or fever, you're evaluating your patient in triage for the criteria for sepsis. You're thinking about suggestions of dehydration or a heat-related illness with tachycardia. You're also looking for other symptoms that may mean they have a stroke or other cardiac emergencies. Don't ignore the potential of vital signs to function as a point of care test. And of course, our caveat with children. They will often not be protective, even when they're severely ill or injured, until immediately prior to profound compensation. So hypotension is not as reliable in children as it is in adults. The EKG, I'm not going to go into a lot here because you just had a wonderful lecture looking at EKGs. But I will say again what my colleague said, and I didn't know he was going to, which you always want to obtain an EKG for syncope. Most emergency departments throughout the world get them for anybody who complains of chest pain. Even the example I gave of a 16-year-old who had chest pain when she coughed. So they can give you more information than an MI, right? An MI is not ruled out by a normal EKG. Dr. Amal Matu, who's the American cardiology emergency maven, always says 10% of people have normal EKG, but you can rule out all of these other syndromes. I'm going to take you had a great presentation, so good examples of those EKGs. A stat potassium level. Why would you get it? There are a long list of concerns for hypokalemia and hyperkalemia. So if I have a vomiting patient with diarrhea, or an intoxicated patient with alcohol, or a patient I suspect of heat-related illness or who's on diuretics, do I need to actually Do I need to be in triage? Do I need to start hydrating them, give them some supplemental potassium? This is going to get the patient out faster. So if I need to try to do a stat, allow me to act very quickly and shorten the amount of time the patient is in the ED, and also make my decision about whether I'm going to be able to fix them and get them out of the ED, or whether they may need to be admitted. And again, hyperkalemia, I'm looking at that normal EKG. I'm thinking about that in patients who have ACE inhibitors, who I think have a heat-related illness or on dialysis. And certainly it could be a new diagnosis of Addison's disease. The ED troponin, again, you had a lot of discussion about that. I'm not going to labor it, but patients with an MI, of course, have a normal EKG. And what does a positive test mean? Again, you as a physician understand better than a nurse practitioner or a PA that it's not only an acute MI, but they could have recently had an MI, recently been cardioverted. Some troponins are not reliable in renal failure, but an elevated troponin can allow you to make a quick decision for admission. All the admitted team, even before all your other tests are back, to give them a head